Good evening all. Today I am going to review two journals which are published in last month of NEGM. Uh, so it is about large core thrombectomy. Hope I am. So the journals published in last month of NEGM about large core thrombectomy. And we will review about large thrombectomies. What we have already know about large thrombectomy and various guidelines and studies relating to that. So, after for major landmark trials in 2015, the mechanical thrombectomy has been a feasible intervention for in patients with acute stroke. And dawn and diffuse trials increase the criteria of mechanical thrombectomy to 6 to 24 hours beyond the normal 6 hour which was proposed in the trials. But there are criteria, volume limitation criteria in dawn and diffuse trials, where the maximum considered for endovascular intervention was less than 70 in diffuse trial and 51 ml in dawn trials. So they have excluded large core infarct from enrolling into their trials, and they used this rapid and rapid software, either CT or MRI based protocol for determining the and penumbra and to find out mismatch selecting patients for endovascular thrombectomy. So, safety and efficacy of thrombectomy in patients with large cohort has not been well in previous studies. So the guideline was the criteria for endovascular aspect score of 6 or greater, or a mismatch between the clinical condition and the perfusion imaging if the patient is selected between 6 to 24 hours. The meta-analysis of this all these 7 randomized trials that in between 2017 showed that there was a subgroup of patients in which the EVT achieved a better outcome at 90 days to medical therapy. In the subgroup of patients, MCS fact affected more than 33% of territory or aspect less than 6. But they found that the intracranial hemorrhage was higher in this group. This was the collaboration did the analysis of all the 7 trials which was published in between 2010 and 2017. So they found out that there is a subgroup which is benefiting by vascular therapy with the large core. So, various studies came for that. The first trial which was the SELECT study, which was as a collaboration, which was as a prospective study in 9 comprehensive studies. They found that they include only 62%, of which found that the EVT produced a functional independence of MRS 0 to 2 better than that of the medical group, and it also related with the functional outcome, infarct growth, and smaller final infarct volume medical treatment. So they concluded that the good outcomes of the patients with the large who receive intravascular therapy, and they have also suggested RCTs to follow to include this idea. So this data was published in JAMA in 2019. This was the first RCT trial studying the effect of large core thrombectomy. Then comes the INSPIRE registry, where they assessed the effect of endovascular thrombectomy in large core group, and they found that the offering EV to large vessel occlusion patients with a large score associated with the greater benefit. And they found that there was a significant shift of MRS 0.3 in the endovascular group compared to non therapy. There was gradual more shift to better group than the uh, medical therapy. Last year, 2000, there was a Japan rescue limit which was published in NEJ, which studied the endovascular therapy for a large ischemic core. And a quick review of this study was: this was a multi-center open trial, randomized trial which was conducted in Japan, involving large vessel occlusion, which is identified by aspects of 3 to 5 using CT or diffusion weighted MRI. If they underwent randomization within 6 hours after the time patient was last seen normal, or within 64 hours if the patient normal, if there is no signal change in the flare indicating infection was recent. So it was last year study conducted in Japan, where they studied a large core infarction of aspect 3 to 5 on CT or MRI, and they included window based on signal change in the flare. If there was no flare change, they included the patient in the late window, and study was in that they did not do any perfusion study or rapid software was used in this study. So this study showed that the patient are selected for endovascular therapy or medical care, and ultimately 6 milligram was given. They were eligible, and this study showed there were 2003 patients of 100 were endovascular group and 102 medical group, and this study showed that there is a percentage of patients MRS score of 0 to 3 at 90 days were the endovascular compared to the medical group, and the shift across the MRS scores favored the endovascular, and found that the improvement of NHS at 48 hours was more in endovascular therapy than of the medical therapy. So this trial was published in last year, and this is also known as Rescue Japan Limit Trial, and they showed that the aspect value of 3 to 5 had a better outcome with the endovascular than they had more cranial hemorrhage. So what is the why these new studies are published? What of these studies? In patients with acute stroke, these studies wanted to evaluate whether EV24 better functional outcome and standard medical care alone. This is the first study. This was conducted in China, and the results are published in the last month of NEGM. This is called Angel Aspect Trial. It's a multi-center randomized trial with a blind across 46 hospitals of stroke centers in China. This protocol was approved by Beijing Hospital, and inclusion criteria was they include patients from 18 to 8 years of age who had an ischemic stroke within past 24 hours with of 6 to 30 and pre-stroke MRS of 0 to 1. And they should have LVO, or CT or angiography. And they include patients of 3 to 5 based on CT within 24 hours with no limitation to the introspective core volume. Aspect 0 within 24 hours with a volume of 70 limited the infarct volume to 100. Aspect value greater than 5 and if the CT done between 6 to 24 hours and infarct core volume of 70 to 100. With the median shift, signs of herniation, mass effect, and high hemorrhage, bilateral strokes, multiple endocrine occlusion were excluded from this study. This was a protocol of the Chinese study. And the randomization was a central time network 24-hour system based on a simple session without satisfaction. And the patient's criteria of IV thrombolysis received either alteplase or urokinase. And the patients in the endovascular group were treated either with a stent retriever, contrast aspirin, or solemn. So they wanted to make them based on the MRS scale at 90 days, and they want to determine whether there was a shift in the distribution score of MRS at 90 days between the trial groups. The secondary outcome they want to measure MRS score of 0 to 3 or NHS improvement of at least 10 points at 36 hours, change in the infarct core volume with a non-contrast at 7 or whatever is earlier, or to MRI 36 hours. They also want to study rate, which is using CT or MRI. And of these safety measures, they wanted to study the incidence of symptomatic ICH within 40 after randomization and on the Heidelberg bleeding criteria. Any within 48 hours, death within 90 days of the stroke onset, and need for decompressive craniotomy during hospitalization. So they are imaging at the baseline at 30 and at 7 days before discharge. They used rapid fire, and core was defined as cerebral blood flow less than 30% of CT perfusion, or ADC of a value of 20 in 10⁻⁶ meter square per second. MRI. So they used the for definition of core, and for canalization they included ETK scale, which is a 7-point scale, and the success canalization was also arterial occlusive lesion grade 2 or 3. So in this study, between October 2020 and May 2022, total of 1,504 patients were screening at 46 centers, of whom 150 enrolled final trial. 30 patients were enrolled for endovascular therapy and 225 for medical management group. So out of the with age more than 80, chronic occlusion, previous MRS score more than 2, who NHS score of more than 30, onset 24 hours. Those were excluded from the study, and 219 patients were included for the medical group for the control group. Median age was 68 years, and most of them were from the Han region of China. So IV thrombolysis were administered to approximately 28% of the each group, and kinase was used in 60%. In interval of stroke or to run was 456 minutes, and median baseline NHS was 16. Median value between case and control was 3, and median infarct core volume was 62 ml. So this is the basic characteristics between groups. They had age similar, and median ages was similar. Solution rate, CA M1, M2 segment almost similar, and aspect score was equally distributed among groups. 20 of each group IV thrombolysis. Medium infarct core was around 60 ml in both groups, and distribution of time onset to was similar between therapy and medical group. What was the outcome? This trial was stopped prematurely because of the evidence of efficacy of endovascular therapy after second interim analysis. So did first interim analysis after the result of 1/3 when 2/3 of patients were completed the study, because they found out that the endovascular therapy was very superior. So there was a shift. Primary outcome, they found out that the shift in the distribution of score of MRS scale and was towards observed in favor of vascular therapy over management with a 1.7. And secondary outcome, the percentage of patients with a score of 0 to 2 in the at 90 days was 30 vascular, 7.6 medical group, score of 2.2, and percentage of patients with score to 3 on 90 days was 47% in the endovascular group and 33.3 in the medical manager group, relative risk of 1.50. When they start safety outcome, that within 40, 6% of the endovascular and 6% of the manager group, and the p-value was not significant. So, but when they studied any intracranial hemorrhage within 48 hours, they found it was more significant the endovascular group. So that the symptomatic hemorrhage not significantly increased in endovascular group. So numerically more patients underwent hemicraniectomy in the endovascular group. Not significant. Mortality within 90, 21.7 in the endovascular group and 20% in medical management group. Other serious events occurred in 90 to 40% in the endovascular group and 38.2 in the medical management group. And dissection or perforation occurred in each of approximately 1 patients in the endovascular therapy. So this is the sum of the primary outcomes. The MRS score at the 90 days was favoring vascular therapy. The second outcomes was also favoring the endovascular therapy. And the safety outcome, the symptom hemorrhage was not statistically, but any hemorrhage in 48 hours was statistically significant in endovascular therapy. This decompression was in the endovascular group, but not statistically significant. Death also not statistically significant. So this is start, which the endovascular therapy, the in amount of 0 to 3 was more compared to the of 5 and 6. 5 means severe disability, 6 means the number of patients with severe disability is very compared to medical group. So when they did the analysis, they found that all the parameters, age more than 75, less than 75, if of run session is more than 6 hours, NA more than 16 hours, they received thrombolysis where the occlusion is IC M1. If the aspect is less than 3 or volume is less than 70 or more than 70, all these parameters, they found the endovascular therapy group was compared to medical. The effect of the endovascular therapy was better in all subgroups. So, what are the limitations of this? The patients of patients receiving IV thrombolysis was very low. This disadvantage the group. Only 28% received the IV thrombolysis because the patients coming after 4.5 years was more in both groups. So only 28% received. So that disadvantage medical management group. The urokinase was which was used for only small safety patients. No patients greater than 5, and in fact, volume 70 to 100 was enrolled in the trial. And the patient more than 80 years of age was enrolled. Trial was conducted in population, and there is a high prevalence among this, and may not be accessible to other population. This was limitation of the study. And they found out that more events of intracranial hemorrhage occur in the endovascular group, but the incidence of symptomatic intracranial hemorrhage didn't differ significantly in groups. So they had a similar that select and inspire two studies. The good prognosis in the endovascular therapy if volumes of 50 to 100 and 70 to 100 respectively. So they concluded that in patients in China with a stroke and a large core infarct due to LVO in the anterior circulation, endovascular therapy in 24 hours after stroke better for months than the medical management alone. ICH was common with the endovascular. To next journal, this was published in the same date in NEGM. This was the Cleveland group. This is called the selected trial. The selected true trial is a phase 3 international randomized open trial with the adaptive management design. This was funded by Stryker Neurovascular, and this was among 31 sites across the US, Canada, Europe, Australia, and New Zealand. Between 18 to 80, stroke due to an and ischemic was on CT as an aspect of 5 estimated 50 to 100, 50 or more based on CT perfusion or RA. CT perfusion used if there is a cerebral blood than 30 and 60 using a rapid software. In this study, upper limit of the volume, they included if the volume is more than 100 also. So IVBA was administered to the selected patients in both groups, and randomization was performed using use of web-based method. And they selected patients from September 2019 to September 2022, and the trial was when the trial was stopped, patients were screened and 352 of patients were for the study. 178 patients assigned to thrombectomy group and 174 with the medical group. So what are the results of this study? The median age was 65, median HS score was 19, and median interval between last known to well and randomized 0.3 hours. Median aspect score was 4, and the medium estimated volume was 80 ml, and 41% were women and 50% were in population. So IV thrombus administered in 28 in the thrombectomy group, 17.3% in the medical care group. They both multiplies and tentaplies. So baseline characteristics were almost similar in the endovascular and medical care group. And equally distributed on the occlusion place, nature score, and aspect score was 4 in both medical and endovascular group. And overall volume was around 80 in both the medical group. And they also calculated the penumbra using the rapid software, but they did not limit based on the mismatch. They studied the mismatch patients also. There was no volume manipulation. Studied about volume more than 100 also. So coming to the outcome, the median score of M4 in the thrombectomy, 5 in the medical care group. When they used Whitney probabilities scale was 0.6 favoring the endovascular group, and the odds ratio was 1.5. Functional independence at 90 days. That means MRS of 0 to 2 was observed in 20% of patients with thrombectomy group and only 7 in the medical group with a odds risk or relative risk of 2.9. They studied MRS was 4 mean MRS was 4 in the endovascular group. In the outcome, MRS at 90 days was in the medical group with a significant relative risk ratio. And the functioning independence at 90 days, independent ambulation at 90 days were all favoring the endovascular therapy. And quality of life was also favoring the endovascular therapy. And this is the distribution of at 90 days. And there is a significant MRS scale, and it is better in the endovascular therapy compared to the medical therapy alone. We can find that patients with MRS 1, 2, 3, 4 were more in the endovascular, whereas patients with MRS and MRS 5 were more common in the medical care group. Coming to safety outcome, when they measured this they found only in one patient in the thrombectomy group and 2 in the medical group. And parenchymal hematoma was observed in 2.8% of thrombectomy group and 3 patients in the medical group. At 68 patients in the thrombectomy group and in the medical group, 70% of early neuronal worsening was in 24.7% thrombectomy group and 27% in the medical care group. Patient who had neurological worsening large at baseline of 107 among patients with a neurological worsening, with 77 among patients without neurological worsening. Procedural complications occurred in 33%. The complications were mainly arterial site occlusion, hematoma, infection. In addition, patients are dissections, 7 had perforations, and 11 had intraprocedural vasospasm. 2 patients had both and intra. So they found where safety outcome was measured. the patient of having symptomatic intrahemorrhage was very less in both the groups. Early neurological worsening was more common in the endovascular group, and death was similar in both the groups. When they did the subgroup analysis, they found that the effect of endovascular therapy was more favoring in the each and every where the age was less or more than 30, ages if more than 20 or less than 20, arterial occlusion presented to the randomization less than 12 or more than 12 or less than 6 or more than 6 hour. Whatever the infarct volume, even if the infarct volume more than 150 ml, that was the final result was the endovascular therapy. And 0 to 3-5 clearly aspect of 3 to 5 clearly benefited with the endovascular therapy. And mismatch was there was no mismatch. It was in the therapy, and if this mismatch if there is a minimal mismatch ratio, then if there is no mismatch, that means mismatch is even if left than and mismatch volume is not more than 10 ml, it also favored the endovascular therapy. So there was both groups with mismatch or without mismatch was favoring the endovascular therapy. And so the fraction of effect persisted in patients with the infarct volume more than 100 ml and also in more than 150 ml. Because but MRS, these patients were less with the they were not having functional independence if the volume more than 150 or 100 or 150 ml. Incidence of intracranial was low in both the trials, but 20% of patients in the thrombectomy had complications associated with the procedure. Early neurological, which is defined as the increase in NH score of 4, was numerically frequent in thrombectomy than the group and was associated with a very functional outcome. Symptomatic hemorrhage occurred in one patient who had early neurological worsening. Potential cause of depression in some of these patients was associated with the perfusion. However, overall, the endovascular thrombectomy was associated with a better outcome than medical care alone. Study also there was a because of the results of the Japan limit trial. This study also ended after the second interim analysis. So the sample size was smaller than anticipated and under for subgroup analysis. As the treatment was an open label, but the outcome was found by exercise who were unaware of the trial group patients. And some patients who were enrolled on the low aspects had lower issues core volumes than intended for the enrollment. Rapids of the vascular compared with the medical care, however, persist in pre-specified analysis, patients were excluded. Only approximately 20% of the patients in the trial received IV thrombolysis before termination. That is only less favorable to the medical therapy, because majority of patients were more than 4.4, and physicians concerns over risk of hemorrhage also prevented them from receiving IV therapy. Limit for both the studies. So they concluded that in patients with patients in North America, Europe, Australia, and with acute ischemic stroke due to large ischemic score, vascular therapy, in addition to medical care, resulted in a better functional outcome than medical care alone. It was associated with the procedural vascular complications. So, criteria of the NAGM also defines based on this results of these trials. And they describe that the benefit of thrombectomy are consistent across age, degree of neurological deficit, imaging characteristics, time of treatment, and geographical location. Despite concerns about the basis of shift in the outcome categories, the result of all these trials that the mortality was similar between the trials. A shift from better occurred across other outcome categories among the patients who underwent thrombectomy. Together, this provides information from more than 1,000 patients with large ischemic strokes in different medical care systems that probably lead to changes in the pattern of care delivery. So it is reasonable that endovascular should be offered to patients with large strokes. It's approximately percent of the strokes if they arrive in timely fashion at a center that is capable of performing the procedure. Patients have an aspect value of 3 to 5 and ischemic score of more than 50. Higher rates of outcomes may be if they increase the risk of intracranial hemorrhage, edema, neurological worsening, and hemicraniectomy. Patients and families should be made aware of limitation of the treatment, anticipated residual neurological result. The improved chance of independent and ability to perform other daily activities in patients with most severe is patients and in the field of stroke treatment. So there are 3 more trials which are pipeline, which this is one is Tesla trial, which is completed by the end of this year. Another is the which is a European trial, and it is also about to be completed in the May of this year. And last year trial is also recruited its patients and about to finish by July 2023. Thank you.
Okay, Jaishankar, thank you very much for the nice presentation, and it's really emphasizing the advantage of endovascular thrombectomy on the medical therapy. I think from all these trials, we are now confident that if you are able to identify some amount of livable tissue, you can go ahead with thrombectomy, even though, so it's all, we know all those things, but only these things are bringing in some confidence and evidence to do us in selected cases. But however, I think it is an individual stroke neurologist call that we choose those patients. Even though these are in trial settings, we will have many variables which would affect the decision to perform the endovascular thrombectomy beyond very extended windows, like the possible outcome, the functional outcome the family will have, the ability of the family to support, and financial conditions. And I think so by these trials, we are understanding that thrombectomy is a tissue window-based thing. But only thing, our ability to understand the salvageable penumbra would be a major thing here, like rapid software. Some of the institutions are not using rapid software. Some of them have the substitution they are using very well. So I think it is highly individualized. So extended window thrombectomy and large core thrombectomy is a call to be taken by the neurologist on the ground, stroke neurologist on the ground. And of course, these trials are giving us more courage to offer endovascular thrombectomy to a better number of patients who otherwise will be severely disabled. So their outcome difference is very significant in the first trial, in the Chinese trial. I mean, Chinese trials are important because it is more pertaining to our population, the Asian population. So I think we have to look carefully into the Chinese trial because there is about 14 to 20% difference in the outcome. So, however, I think it's highly an individualized decision by the treating stroke specialist or the operator, endovascular person, to determine which patients will be benefited, considering to many local factors. So, but it gives us, in principle, some courage and some evidence to go ahead with extended endothrombectomy in some of this. But we don't know. We see this large core thrombectomy and some of the outcomes. And Dr. Didi used to talk about the early thrombectomy and decompression. So I think that's another way to look at it. But the outcome may be good, may not be good. Of course, the trials are showing better outcome, but it's a call to be taken by the treating neurologist, looking into the overall prospect of the patient from financial, social, supporting, and other aspects. And family should be well educated about it. Not at all always a rosy picture. We'll have bad outcomes also. But however, these evidences are giving us some amount of protection and some amount of confidence to go ahead with thrombectomy in selected patients with little bit dark in front. Okay, next. Any comments from any other? Zubair Ahmed.
Yes, sir. I'm here, sir. Good evening, sir.
Kindly give your comments from Bombay side.
Sir, regarding the success of thrombectomy, I think the mechanism of stroke as well as the type of clot plays a very significant role. The occlusion by a red clot and fibrin-rich clot. So, what's your take on that, sir?
I think I think many of the teachers, our senior teachers, like Dr. Matthew and all, they used to strictly follow these things. Suspected what they use the endovascular type of endovascular like suction aspiration thrombectomy versus solitary retrieval for these when they differentiate these and they look into the hypertensine and determine it is RBC rich clot, and then they will go for more of a solitary thrombectomy, and if there is a fibrin rich clot for atrial fibrillation, they will go for more of aspiration or penumbra and other techniques. But yeah, since these are all, we do not have, I don't know whether there are any trials you may be aware of trying into different mechanisms of stroke and trying different type of modalities of EVT for acute large vessel occlusion stroke. Maybe there will be some trials I'm not aware, but this is what our seniors used to tell us. So I think it will be true also because they have large number of cases in experience.
The problem is, sir, I had just had a discussion with one of the students. So they were telling that there is, I think he had put up the question in the group. How to know if the vessel is reoccluding and at what time to repeat angio after thrombectomy? Hello, sir.
Hello. What was the question, Suvir?
Sir, in the chat box, there is one question. How to know if a vessel is reoccluding and at what time? Because I think, sir, because some centers used thrombaspiration as a major technique with the penumbra adapt technique. I think the success rate post thrombectomy is not as good as the solitaire or the solumbra technique. So so that is why the question is there in the group chat box. How to know if vessel is reoccluding and what time to repeat angio after thrombectomy? And thus regarding the success rate of thrombectomy in patient.
Okay, how to know whether the vessel is reoccluding?
Yeah.
So I think reocclusion is more common with, as we were discussing last time, it was more common with ICAT disease. So in those situations, we used to wait for some more time because after the aspiration or some of the thrombus, there will be underlying disease in the of ICAD in the MCA or basilar or wherever, and usually we after recanalization, whether a balloon is required or a stent is required, this is by just waiting like maybe 15 to 20 minutes, at least half an hour, we'll wait and check. Give it check shoot for recoil. If there is a recoil, we'll go for a rescue angioplasty, or even after that, if it's we'll go for a rescue stenting. I think reocclusion rather than the technique of what I think is whether the technique is aspiration thrombectomy or solitary thrombectomy, the reocclusion is more of due to the underlying arterial disease rather than, or otherwise you should have fibrous float which is not coming into the solitaire, or is not, you are not aspirating. So reocclusion is more common with underlying disease, arterial pathology, rather than the mode of the modality of thrombectomy. Anybody else will have comment? Hello, Jaishankar. Hello. Hello.
Hello, sir. Hello.
Hello. Audible? Hello.
Yes, sir. I am Jay Shankar.
Jaishankar, is it audible? Like any other questions in the chat box?
Actually, one doubt in the chat box is not directly related to this, but asking about how to differentiate between thrombotic ICA occlusion and chronic occlusion, and is it necessary to do mechanical thrombectomy if we suspect a chronic occlusion in DSA? That's one query in the chat box.
Yeah, like chronic occlusion, like that's a major chronic occlusion or a chronic stenosis with occlusion due to a plaque change. That is the problem. Now, chronic occlusion usually we will not do thrombectomy there. I mean, chronic occlusion means it is compensated. Usually, what we'll see, a lot of ICA disease. Patient will have a small like mild hemiparesis. You look at the CT angiogram or DSA, there will be total occlusion of the ICA, and there will be a small infarct in that corresponding brain. So those things, and the patient improves also because he's already a chronic stenosis with some occlusion resulting in some small stroke, and he recovers. So whether we have to do thrombosis in acute situation, we would be definitely trying to open it up because we do not know whether. So then we look at their perfusion will help us. Like if you look at the rapid software or other thing, if what is the penumbra, if there is a large penumbra and the carotid is occluded, we definitely will open it up. So otherwise, it's a seemingly a CTO, and there is a small hemodynamic infarct or something there, and mild hemiparesis NH is not good. If you are not seeing any penumbra, I think it's a well compensated circulation. There is maybe a chronic functional occlusion. On those situations, whether warranted to open it, we do not know. We are not very sure. So, but if you feel that in that way, perfusion would be useful. So if you are seeing a large area of penumbra, your arteries occluded, we will definitely open up. If there is a good perfusion in the perfusion scan, there is a good CPF and good CVV and everything. So why do you want to open it up like it's a seemingly CTO? Like CTOs, we used to open up when there is a tail embolism or recurrent strokes involvement. I don't know what is the newer view, what are the new views about it. I'm not very sure. This is what I practice. So we look at the perfusion, see whether there is a penumbra, then we'll open up that. The brain is not at risk.
Basis.
Yeah, brain is not at risk. We won't. If there is no deficit, we will not do it. But mild symptom, no penumbra, only a small lacunar infarct or a small area of damage with a full perfusion. Whether we have to open it up is the question. We don't know. We may benefit. We don't have any trials or evidence for that.
Sir, one doubt are based on studies, sir, just in here, sir.
Yes.
Sir, based on these studies, the role of perfusion studies will go down. Means.
Yeah, of course, perfusion studies. Perfusion studies only one method to identify if you have from the aspect score to the CT angiographic source images to the perfusion. No, it's only a matter of how you understand perfusion, and with the rapid software will give you an easy thing. That is why Otherwise, also you can just look at the simple CT angiogram. You can the three-phase CT angiogram. You know how it works. Like we have been discussing this all the castle course. How you look into the three-phase multi-phase CT angiogram and understand whether the perfusion is good or there is a how good is the collateral, how bad is the collateral, and all we can understand. So if there is a very even source images totally black hole means it's a very bad area. It's a totally poorly perfused area. So that will give us. That's why escape trial is about that. No, their paradigm was totally CT angiogram based paradigm. It's
Yes, sir.
collateral imaging, but Dawn and Diffuse were doing a rapid based software based perfusion thing. That is, it's easily. I think beyond extended window thrombectomy, it will be safer from our side to have perfusion. Extended window thrombectomy, 6
Yes.
to 24 hours. I think that will remain. That will make us safe. This problem is not because you are doing right, but you should be safe also. No, when you somebody legal things should not be there. So how can you do that? They look at the trial evidence is showing that you have done perfusion. So if you have not done perfusion and open the vessel, hemorrhage, transmission, death and all, maybe in case there is a legal battle, you have to defend. So I think that's a good work of perfusion by Bijoy in Lancet published at this for PROVE trial. Actually, I was also enrolling into that trial, but that is giving a comparison of perfusion. You compare the perfusion, whether the decision, we have done perfusion for all the patients whom we have selected for endovascular thrombectomy, and that perfusion report was not looked into. Then, retrospectively, they have looked into the perfusion report and they compared whether our decision on the thrombectomy or thrombolysis, whatever modality we have done, whether it is affected by the perfusion scan. So we make a decision by the perfusion scan, and you compare the decision which you had made based on CT angiogram. So that's a good study. That's called PROVE. It has been published in Lancet, I remember, but personally I have not gone through the detail. I've seen the full paper. I think it is published. PROVE. The trial is called PROVE. PROVE it investigator. Actually, you have to go through that. So he was also talking like the perfusion can become obsolete, like it may become less relevant in the times to come.
So another doubt is how good is assessing the perfusion with the DSA, this assessing the collaterals and all, when compared to doing perfusion.
Absolutely. By DSA, we know everything now. That was actually
Okay.
these trials were based when the endovascular trials are not fully into thing. Nowadays we have DSA straight away, no. So I think it's not that we know perfusion, how the perfusion of that area. Parenchymogram we can see, we can look in the timings, and it's very easy. So these trials were actually done at the time when we were struggling to get evidence for endovascular, like before designing the escape and all. So I think that was the time. That was a time where it was very sad and everybody was so frustrated. We want to create a positive trial. So we were pushing all for designing designs to make positive trials in endovascular, because all the three trials were negative, and the American insurers stopped sponsoring endovascular from it. It has become a totally very bad state for 3 years. So people started designing randomized trials. The Dutch guy started the first trial that Mr. Clean. No, they made mandatory enrollment of everybody undergoing thrombectomy only under the preview of a randomized control trial. That's why they were able to finish very fast. There was a government order in Netherlands, like nobody will undergo endovascular without enrolling into randomized trial. So that is a very bold decision by the government and health ministry. So they were able to recruit 600 some patients immediately in another 1 to 2 years. So that's why they have published first. In Canada, there were a lot of ethical issues. Some consultants were not willing to enroll. They want to do thrombectomy in young people. So like that, there were a lot of issues that time. But after this thing has come, now we can straight away go. We are talking about direct thrombectomy, shift there, all those things. No? So I think I think PSA is a better way to understand, since if you are straight away taking it to be safe.
And similar things can be achieved in multiphasic CT also. No? So, like if you, while doing CT angiogram,
It-
uh,
Absolutely.
comparing the different
It
phases
depends
and
yeah, absolutely. It depends upon how your eyes are trained. No? You will be comfortable if you are trained in some because it is a major thing. You will be very smart in picking up this in CT, basic CT and all. But if you're not, if you're in rapid trained, you'll be more accustomed to rapid. So you crave for rapid because it's quick and easy. It depends. Like, it's all how you are trained and how you are accustomed to. But the principle is the same.
Yeah. Tragically, there is no perfusion that being done.
I know.
So,
Means if you are a very good cath lab available, so we have a little bit of struggle to get the cath lab because of multiple specialties are using cath lab, like pediatric cardiology, adult cardiology, peripheral vascular, radiology. We have 4 cath labs, but all will be busy. So it's a bit not, no, depends upon the center. Cath lab availability is the problem. Okay, anyway, a very nice presentation.
Yeah, sir. It's time already 50 minutes. Shall we wind up, sir?
Yeah.
Thank you so much.
Yeah,
Sir.
sure. Thank you.
Thank you, sir.
Thank you so much. Bye.
Thank you, sir.